Yeah, thank you for the privilege of the podium, and let's continue on what Sal started there a few minutes ago, talking about endoscopic vacuum therapy. I do have some endoscopy disclosures here. I'm not going to show you any specific tools or products made by any company that you can purchase here in the U.S., so they should probably be not particularly relevant. So we've talked previously in this session, anastomotic leaks are usually managed with surgery, but there are lots of different ways to manage them endoscopically. And obviously, as surgeons, we all know that these are rather morbid operations. Many of us may be familiar with the concept of endoscopic vacuum therapy to treat external wounds from our open or minimally invasive surgical practice when there's problems. And we have an understanding of the mechanisms of how these devices work with suction, drawing wound edges together. The concept of endoluminal vacuum therapy actually started in Germany in the early 2000s, and this was initially designed for low rectal leaks after LAR. So it was designed to save those very high-value anastomoses that if you get it wrong once, it's probably gone for forever. The mechanism of action here is really to control the source of infection. But obviously, as we know from our open practice, when you use a wound vac, it's debriding and decontaminating with each sponge exchange. And there are thoughts that the negative pressure suction actually encourages tissue reperfusion. When we talk about endoscopic vacuum therapy, there's really two ways to describe it. We talk about intracavitary. The defect is big enough, you can take the sponge and put it directly inside the cavity that's there. Or we think about intraluminal, where the defect is smaller, or perhaps you can't get it in the foam into the hole, so you just leave it inside the GI tract next to the mucosa, adjacent to the site of the leak. Who do I do this on? Well, I think Dr. Dosimo gave a really good algorithm, and I think Sal and I think probably a little bit the same because we did train a little bit together. I try to close most defects, but if I can't, then we move on to endoscopic vacuum therapy. So thing one, there should be a leak in the GI tract. Here's a patient with an obvious sleeve leak, and there's obviously a big cavity that we can access by endoscope. Pretty much any part of the GI tract that you can reach from above or below is theoretically fair game. If there's a fistula tract that you can access it through, you could theoretically do it that way as well. Occasionally, we'll do it by going down through like a G-tube tract to get to a posterior gastric perforation. The patient should be clinically stable. And again, I think the theme of today, and folks have said it, is if the patient has hard surgical signs, then they should be going to the operating room. For colorectal leaks in particular, fecal diversion is very, very helpful. While it's not mandatory, you'll see that success rates are just much higher if they are diverted. I usually try to initiate this within 4 to 6 weeks. Once things become a bit more chronic, it's a lot more challenging to get them to heal. And as I said earlier, if the leak should be not closable by some other means, again, this is my personal preference to try and take small leaks and close them endoscopically if at all possible. The problem with this is that you have to make it. If you're outside the U.S., in Europe in particular, there are commercially available versions of this for upper and lower endoscopy, but here in the U.S., we have to make it ourselves, and so you'll need a nasogastric tube, some suture, and some black granufoam. There are a variety of papers that can explain to you very detailed steps on how to make it. I do want to highlight just two things. Number one, I usually double suture it in place. One of them is sort of a suture ligature, and then the other is a suture loop that you can hold on to. The second is that when you put it in, and obviously you got to put it through the nose and out through the mouth before you attach the foam. That's lesson one you'll learn on how to do it wrong. But you have to tie the sump portion off. If the drain is sumping, it's not, you're going to get an air leak warning on your vac, and so you've got to disengage that quite thoroughly. I usually tie a few knots into it to make it not work. If you're doing lower vac therapy, there are actually some good videos and pictures out there about ways to make this comfortable and tolerable for patients, most notably kind of taping it up and over a hip as opposed to leaving it kind of dangle down by a leg is recommended by some folks. This is an extremely short video of doing this. This is a patient who had a gastrectomy. What you're looking at is supposed to be an esophagogastric anastomosis. It looks much less like an anastomosis and more like a big cavity. And what you're seeing there's the jejunum is dangling kind of free in the breeze. This has a near complete disruption. There's a few posterior stitches maybe hanging on. What I'm going to show you is then essentially a very fast-forwarded view of how we do this. You know, the foam is essentially dragged into position, and here we're starting with intracavitary therapy. And over the course of several weeks, we fast-forwarded several weeks here of doing exchanges once or twice a week, you can see the anastomosis is mostly back together. There was a lot of suture there. We did a lot of debridement as well, and there are other adjuncts that go along with this. A few points to consider if you're going to do it. Nursing considerations. Despite you tying that tube in a knot, some dutiful nurse is going to try and undo this in the middle of the night, thinking that the tube needs to sump. And so it oftentimes is helpful to leave a little warning label on it that says, like, this is not a nasogastric tube. Don't put food down it. Don't put medication down it. Don't untie the knots. Nutrition is obviously important in patients with a leak, and there are ongoing debates about how best to do this in an eVAC patient. Is it better for TPN, because that can run right through the operating room, or are enteral feeds better because they're better in general? If you're going to do enteral feeds, do you bite the bullet and put a feeding tube distal, or do you kind of struggle with a nasogastric or nasojejunal tube parallel to the vacuum therapy? And that's beyond the point of this discussion, but those are problems. When to stop the therapy is also important. Obviously, if you can't get a vac in it anymore, that's probably good. If the leak site is a cavity that is now self-draining, that's a good time to stop. Or if it's just completely healed, then I think you're done. There are a few contraindications listed in the literature. A visible vessel near or touching the sponge. This is, I would say, a relative contraindication. I've vac'd on both the heart and the great vessels. I would label them blood vessels, and they're visible in the field, and so you can get away with it sometimes. If the patient cannot go back at intervals for therapy, if the patient is too sick, too hemodynamically unstable to undergo the general anesthesia that's necessary for this therapy, or if the leak connects to the atmosphere, some people say that is a contraindication. I'm going to show you a therapy that I've done. I know Dr. Fung has also done this as well, which is called kissing vac therapy. And this is a patient with a huge sleeve leak that communicates directly to the skin surface there. So it's trying to become a fistula, and we don't want that. And so the way to make this not become a fistula is to get this tract to heal from the edges, from the middle to the edges. And so we're going to put a vac that goes down through the skin and gets pulled back inside the cavity. This is going obviously through a fascial gap that exists. And then we're going to put our eVac on the other side, and those two foams will touch, and then you withdraw them side by side. Does this work? This is some work from Steve Leeds looking at upper GI leaks. This is great data from the US, 83% closure rate, although very labor intensive. When you look at lower leaks, obviously this is favored over stents, and the mortality favors doing eVac as opposed to other therapies. For lower anastomotic leaks, this is actually a meta-analysis that recently came out in 2022, 24 studies, with a mean of 6.8 exchanges over about a month or so, with an 81% success rate. Again, these are high-value anastomoses, and if you can salvage it, your patients are going to be happy. As I mentioned earlier, the majority of these folks were already diverted, and they had a 12% complication rate, but the complications are what you'd expect. This is not from the therapy. This is from having a leak, a stenosis, an abscess, or fistula formation, and some bleeding. So I'll conclude this is both safe and effective for managing leaks. It works well for larger leaks or those that have a lot of contamination. It's labor intensive. You've got to do it once or twice a week. If you're the only person in your group doing it, it becomes a slog because it's now interfering with your regular schedule of events. And so having partners who can share this heavy lift is also very helpful. Look forward to questions in a few. Thank you.